Hello, thank you for joining today's NCCN webinar for patients inflammatory breast cancer. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon. The NCCN webinars for patients complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Rebecca Aft. Dr. Aft is the Jeffrey Moley Professor of Surgery at the Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine. Following Dr. Aft, we will hear from Dr. Jerome Krishnamurti. Dr. Krishnamurti is Associate Professor of Medicine, Division of Oncology and Hematology at Fred and Pamela Buffett Cancer Center. And our third presenter today is Ginny Martin, Executive Director and Patient Advocate from the Inflammatory Breast Cancer Research Foundation. Now I will turn it over to Dr. Aft.
Hi, and welcome to our overview of inflammatory breast cancer. So inflammatory breast cancer is one of the subtypes of breast cancers that we see not commonly among our breast cancer population. And usually these patients present with a clinical presentation. There is a defined definition of inflammatory breast cancer, which I've listed here on this slide. And that's the rapid onset of erythema, which is redness, edema, swelling, and something called peau d'orange appearance. And that's skin that looks like the skin of an orange. It has a ridged or pitted appearance and abnormal breast warmth with or without a lump. The symptoms usually have been present for less than 6 months. And the erythema usually covers about a third of the breast. Initial biopsies from the breast usually show invasive breast cancer. And the reason why the breast takes on this appearance in inflammatory breast cancer is because the cancer cells invade the dermal lymphatics and thus block them. So fluid accumulates in the breast, causing it to have this erythematous appearance and pitted orange and orange peau d'orange-like appearance. So this is an example of women who present some presentations of inflammatory breast cancer. On the bottom left, you can see that this breast is red and swollen. And on the next one, the middle panel, you can see that there's erythema and swelling. And the swelling has happened such that the nipple is almost inverted. But this can be very subtle in patients. For example, in the last panel on the right, you can see that this patient has some swelling of her breast around the nipple areolar complex and also some mild erythema. So it's possible, and in many cases, inflammatory breast cancer can be mistaken for a breast infection. So there are some algorithms for diagnosing inflammatory breast cancer. If it looks just like inflammatory breast cancer and the index of suspicion is high, and you suspect, and if a clinician suspects inflammatory breast cancer, then usually a biopsy is performed and then subsequent imaging. If the clinician thinks that this is possibly an infection and suspect a benign etiology for the warmth and redness of the skin, then usually antibiotics are given to the patient and the patients are reevaluated at 2 weeks. If there's no other imaging of a mass, which may or may not be present in inflammatory breast cancer, then the clinician can escalate it to a breast MRI, which may be more diagnostic for inflammatory breast cancer, and then to a biopsy. But one thing we don't want to do as a clinician is to miss this diagnosis because these cancers can be very aggressive. So these are some examples I've downloaded from the literature showing some examples of inflammatory breast cancers. And in the panels on the left, you can see patients, for example, this patient in panel A, she has very minimal erythema. Her breast looks larger than, her left breast looks larger than the right, which is due to edema. And if you look at the imaging of this patient, this is actually a mammogram, and you can see the right breast looks fairly normal. That's a normal appearing breast. But the left breast, if you look towards the bottom of the breast, you can see that the skin is very, very thickened. In panel B, this would be an MRI. And this shows, again, a patient with inflammatory breast cancer, but she has very minimal erythema or redness of her breast, but she does have edema. And you can see that the breast tissue is pushing around the nipple areolar complex, causing the nipple to retract. And on examining the MRI, you can see that the left breast looks normal. It looks normal. The skin around the breast is very thin, but in the left breast, there's very thickened skin and there's not really any mass present. The same in panel C. You can see that the breast doesn't look, I mean, there's some erythema and a little bit of swelling. And on the MRI, you can see very clearly that the breast has increased uptake of the gadolinium, which is the white, causing the breast to appear white, and the skin is thickened. Panel D is probably a more characteristic inflammatory breast cancer, and you can see the breast is erythematous as well as swollen. And again, the MRI depicts the skin to be thickened, and there's no mass. In panels E and F, the findings are much more subtle. You can see that this patient just has a little bit of skin thickening under her right breast. You can't really even see it, but you can see it on the mammogram very clearly in the right breast. She has this skin thickening at the bottom portion of her breast. And in panel F, you can see that this patient has some thickening, some erythema, but very minimal swelling. But it clearly on the breast MRI, you can see that there's increased uptake of the gadolinium as well as increased uptake and thickening of her skin. So you can see why this might be difficult to diagnose as a clinician and why we need more interventions, such as imaging, to make this diagnosis. So once we suspect inflammatory breast cancer, there are two methods for diagnosing. One is a punch biopsy, and the other one is an image-guided biopsy if there is an underlying mass. And if you look at the left panel, this is an example of a punch biopsy. And what we do is we take a circular blade and we numb up the skin, and then rotating. This shows a punch biopsy being performed on an arm. But you can see that we sort of rotate this blade into the skin and get a full thickness piece of skin. And an example of the type of tissue that we would obtain is shown far on the left. And this would be an example of a punch biopsy. And at the very top are the skin cells, and the skin looks fairly normal, but underneath the skin are these lymphatics filled with these cancer cells, which are these dark blue cells, which is the reason why on imaging, it gives the skin a thick appearance. If there is an underlying mass, then the patients usually undergo a core biopsy to make the diagnosis. Once the diagnosis is made of inflammatory breast cancer, we usually perform staging studies. This can be a CAT scan with a bone scan or a PET scan. And I've shown you two examples of patients with inflammatory breast cancer. What a PET scan looks at is uptake of something called FDG glucose. And so inflammatory breast cancers, as well as other breast cancers, have higher metabolic activity. So they take up more of this dye. So for example, in this whole body sort of outline of a patient, you can see that she has uptake in her liver and her hearts. The dark area at the bottom of the picture is her bladder, and her kidneys also have uptake as this is excreted out through the body. But if you look in her left breast, you can see that she has actually her whole breast has increased uptake. There are some specific areas of uptake indicating an underlying mass. And then this patient has multiple axillary lymph nodes involved. And if you look at the panel immediately below her, you can see that she has uptake in her breast. So this patient likely has an underlying mass. In the panel on the left, you can see this patient has diffuse uptake in her breast and only one lymph node that has uptake in her axilla. So if we don't find any distant disease, then we treat this to cure. And the first step is, after our entire workup, which I'll go over in a second, is systemic treatment. So we first do a history and physical exam, and then we do labs. We review the pathology, we obtain a biopsy, review the pathology. We determine what's called the estrogen receptor status, the progesterone status, and the HER2 status. If the patients are premenopausal, we do fertility counseling, genetic counseling, if the patient's at risk for hereditary breast cancer. And then to help us later, down the line, we do bilateral diagnostic mammograms. As I mentioned, a CAT scan or a PET scan. Also, many times we'll do a breast MRI to determine the extent of disease and to evaluate the other breast, or even to help make the diagnosis. And at this point, after we've completed this workup, we refer the patients to medical oncology for systemic treatment. And I'll turn it over to Dr. Krishnamurthy.
Thank you, Dr. Aft, and thank you, NCCN, for this opportunity to present on the topic of inflammatory breast cancer. So I'll be covering the systemic treatment of inflammatory breast cancer. So there are various histologic subtypes of that breast cancer can be divided into. On the left side, you can see there is in situ carcinoma, which actually means that the cancer is confined within a capsule. We sometimes refer to this as stage 0 breast cancer. And between those, there is a ductal in situ carcinoma and there is a lobular in situ carcinoma. Ductal is the one which is kind of still considered a precancerous lesion, whereas lobular carcinoma in situ is no longer part of the staging system for breast cancer and is just considered a marker for development of breast cancer later. As far as invasive breast cancer on the right side is concerned, ductal and lobular types are the most common ones, whereas there are many other subtypes of invasive breast cancer that are less common. And between those, they are usually divided further into well-differentiated, poorly differentiated, and moderately differentiated, which kind of gives us a clue as to how fast growing or how fast multiplying these cancer cells could be. So typically when a patient is diagnosed with invasive breast cancer, the pathologists run these tests on the tumor specimen. They primarily look for these receptors: estrogen receptor, progesterone receptor, and the HER2 receptor. So here I've put the estrogen receptor representative slide. It's a nuclear receptor. So the brown areas here are kind of showing positivity for the estrogen receptor. On the other hand, HER2 is a membranous receptor. So we are looking for which areas are brown on the membranous side. And a lot of times where HER2 is reported as equivocal initially, we do a confirmatory test called FISH, which actually looks for the gene amplification and looks for the ratio of this HER2 to the centromeric portion of chromosome 17, looks at the ratio of this and tells us whether this is amplified truly or not. And if amplified, it's a HER2 positive cancer. If not, then it's a HER2 negative or a HER2 low cancer. So first, I'll talk about the estrogen receptor positive inflammatory breast cancer, how we manage this type of breast cancer. So typically for managing inflammatory breast cancer, as Dr. Aft mentioned, systemic therapy is usually administered first. And regardless of biology, typically combination chemotherapy is administered first. And subsequently, patients undergo mastectomy and axillary lymph node dissection, followed by radiation, followed by adjuvant endocrine therapy, which we offer for at least 5 years. and it is usually based on the menopausal status. In a lot of patients who are premenopausal, we may prefer tamoxifen. In postmenopausal patients, usually aromatase inhibitor. And typically in premenopausal patients, especially those with inflammatory breast cancer, we may also consider ovarian function suppression, which has been shown to have better outcomes than not having ovarian function suppression, especially those who have high risk disease. Then there is role for targeted therapy in the form of adjuvant abemaciclib for 2 years in those with high risk disease. This is in addition to the endocrine therapy. And then you could also consider adjuvant olaparib in certain patients with germline BRCA mutation. BRCA is a mutation which puts patients at high lifetime risk for development of breast cancer, ovarian cancer, among other cancers. Olaparib belongs to a class of drugs called PARP inhibitors, also known as poly-ADP ribose polymerase inhibitors. It is approved in patients who have residual cancer found on the final surgical specimen after they've received systemic therapy prior to surgery. And in case of estrogen receptor positive disease, they also have to have certain lymph nodes positive, certain amount of residual disease, and there is an online nomogram which helps us determine whether they are eligible for olaparib or not. And if we offer it, it's usually offered for 1 year. Tamoxifen is a drug which has shown significant reduction in breast cancer mortality and reoccurrence. And typically we offer it for at least 5 years. There is evidence that some patients may benefit from 10 years of tamoxifen as opposed to 5. And there is this thing called a carryover effect, which helps reduce the risk of late reoccurrence of breast cancer. Even if patients were to take it for only 5 or 10 years, the carryover effect goes on for multiple years, even beyond the duration of how long they took the tamoxifen for. And the benefit has been seen across all age groups, irrespective of menopausal status. And it is a selective estrogen receptor modulator, whereby the binding site for estrogen is no longer available because this drug is able to modulate the receptor. It usually does not increase risk for osteoporosis because it's not truly reducing estrogen in the body. It is approved in both early and advanced stage disease. And we have to worry about drug interactions with tamoxifen, especially many antidepressants like selective serotonin reuptake inhibitors, particularly drugs like paroxetine, because they compete with this CYP2D6 enzyme, which actually is important for metabolizing tamoxifen to its active metabolite endoxifen. So many of these antidepressants compete with this enzyme, due to which there could be reduced activity of tamoxifen. So that's the reason we counsel patients that if they are about to be started on an antidepressant by their primary care physician or anybody else, they should definitely inform them that they are on tamoxifen. Tamoxifen can also cause cataracts in the eye, so we counsel patients regarding making sure that if they feel that the cars coming from the other side, the headlights just look too bright than they usually did, then they should report it to us. It can also increase risk for blood clots. So we do counsel patients to take breaks in between long car rides or long flights. Although the risk of uh, blood clots with this drug has been in the range of 2 to 3%, but it's important to be aware of that. This drug can also cause endometrial cancer. So we do recommend for patients to see their gynecologist once a year and get their endometrium evaluated, especially for thickness. And then hot flashes are probably the most common side effect of this drug that we see in roughly 15 to 20% of the patients. Mood changes can happen in some. Vaginal discharge is commonly seen, and then depression can happen in up to 5% of the patients. Typically for hot flashes, we consider drugs like duloxetine or venlafaxine, which are again also antidepressants but work very well. Among these, probably venlafaxine is a better drug in combination with tamoxifen due to less interaction through the CYP2D6 enzyme system. The other drugs that we use in estrogen receptor positive disease are classified as aromatase inhibitors. There are 3 of these drugs, anastrozole, letrozole, and exemestane, which are commercially available. And these are prescribed again for at least 5 years. We consider it in certain patients for 10 years if they are higher risk. Again, have demonstrated prolonged disease-free survival and time to relapse, and reduce the risk of development of distant disease or metastases, as well as contralateral breast recurrence, that is recurrence in the other breast. They reduce the conversion of peripheral estrogen, and hence they do increase risk for osteoporosis. They can also cause myalgias, arthralgias, where you can consider an antidepressant like duloxetine, which seems to help with the arthralgias. They can also cause hot flashes, mood changes, can also cause high cholesterol. Studies have shown that all the three aromatase inhibitors have very similar efficacy and side effect profile, but due to unclear reasons in clinic, when we switch from one to the other, patients do seem to feel better. And that's just the practical aspect of using these drugs. So management of inflammatory breast cancer, that is estrogen receptor positive but advanced stage, where the cancer has gone beyond the primary organ, which is the breast, to a distant organ like liver, lungs, bone, or brain. Unfortunately, it becomes incurable but very much treatable with the various options that we have. Generally, there is no role for surgery or radiation in this circumstance, unless for palliative purposes or for quality of life purposes. First line treatment typically involves using endocrine therapy like one of the aromatase inhibitors with a CDK4/6 inhibitor like ribociclib, palbociclib, or abemaciclib. Usually, since these two are oral drugs, the endocrine therapy as well as the CDK4/6 inhibitors, these are fairly well tolerated by patients. Upon progression, we usually consider either an intramuscular selective estrogen receptor degrader, which has been referred here as a SERD, like fulvestrant. And we could also consider an oral selective estrogen receptor degrader like elacestrant, which was recently FDA approved, but elacestrant is restricted to those patients who have an ESR1 mutation, whereas fulvestrant does not require that. We usually reserve chemotherapy for those with visceral crises, which actually means that the disease is very rapidly growing and could result in impending organ failure, or disease where endocrine therapy has all been used and exhausted, and then you pretty much have chemotherapy as the option. You could also consider a drug called trastuzumab deruxtecan, also known as Enhertu, for HER2 low breast cancer patients. HER2 low is basically patients who have either a HER2 of 1 plus or 2 plus with FISH non-amplified, and who have progressed on at least one line of endocrine therapy and one line of chemotherapy. They're eligible for trastuzumab deruxtecan based on the excellent results of the Destiny Breast 04 study, which led to the FDA approval for this drug in this particular population and this particular setting. If patients have bone lesions, we typically use bisphosphonates like zoledronic acid, which is administered intravenously every 3 months to reduce the risk of fractures. Or there is another option in the form of denosumab, which is a subcutaneous administration monthly. The role of systemic therapy in this type of disease is palliative. That is, we are trying to keep disease at bay and trying to improve quality of life of patients, but we may not be able to get rid of the disease. At least theoretically, that's what we think, that this type of disease cannot be cured. We always should assess the performance status of patients, and involving palliative care services early in care has been shown to improve outcomes in patients. And we should always be aware as to when we need to introduce the discussion of hospice and goals of care with patients. And it's always important to have advanced directives available with these patients. Then switching gears to the HER2 positive inflammatory breast cancer. So even here, I'll focus initially on the localized disease and then move on to the advanced stage disease. So typically the localized HER2 positive disease is treated with neoadjuvant chemotherapy with anti-HER2 antibodies, trastuzumab with or without pertuzumab, followed by mastectomy and axillary lymph node dissection, then radiation, and then typically adjuvant trastuzumab with or without pertuzumab if they achieve what's called pathologic complete remission, that is, no cancer is found on the final surgical specimen. But if there is cancer found on the final surgical specimen, then we prefer to use adjuvant trastuzumab emtansine, also known as Kadcyla, which is administered every 3 weeks for a total of 14 doses. And there could also be a discussion for adjuvant neratinib in these patients, which is an oral pill belonging to the class of drugs called tyrosine kinase inhibitors, which is FDA approved in patients with HER2-positive breast cancer who have finished their adjuvant anti-HER2 antibodies, which are given intravenously, or even Kadcyla. And beyond that, you could consider discussion regarding neratinib, which is usually given for 1 year. But the caveat here is that neratinib was studied in the days when we did not have pertuzumab and when we were not using trastuzumab emtansine in the adjuvant setting. So those populations, the benefit of neratinib is unknown, but it could be a discussion in patients regardless. As far as advanced HER2-positive inflammatory breast cancer is concerned, this is again incurable but treatable. Generally, again, the principle is same, no role for surgery or radiation unless for palliation. First-line treatment usually is a taxane with trastuzumab and pertuzumab if it has not been recently used in the adjuvant or neoadjuvant setting. Second line typically is trastuzumab deruxtecan or Enhertu, or you could use tucatinib with trastuzumab and capecitabine, and both these options seem to cross the blood-brain barrier and act intracranially also. Very important in HER2-positive breast cancer because this cancer can go to the brain. Then there is trastuzumab emtansine or Kadcyla, which could also be used if not used previously. And then we have the option of lapatinib with capecitabine. There are other options like neratinib with capecitabine. There is a newly approved drug margetuximab, which could also be considered. Because these patients, if they have bone lesions, they're at increased risk for fractures. You should consider bisphosphonates or denosumab, just like in any other type of advanced stage disease. And the role of systemic therapy is palliative. We should again assess performance status. Palliative care, hospice, and advanced directives have an important role. Then moving on to the estrogen receptor negative and HER2 negative inflammatory breast cancer, also known as triple negative inflammatory breast cancer, because typically these patients have the estrogen, progesterone, and the HER2 receptor being negative. So that's why the triple negative. So localized triple negative inflammatory breast cancer is treated again with neoadjuvant combination chemotherapy, but there is also a role for combining it with immunotherapy. Pembrolizumab, which is a checkpoint inhibitor, a PD-1 antibody, which seems to improve the chances of not finding cancer on the final surgical specimen when combined with chemotherapy, and at the same time also improves survival outcomes for patients. Typically, after finishing the 6-month-long treatment with chemotherapy and immunotherapy, patients undergo surgery and then radiation. And then we also give them adjuvant pembrolizumab, regardless of pathologic complete remission, for 9 more doses. You could also consider adjuvant olaparib for 1 year in those who do not achieve pathologic complete remission after having received chemotherapy and immunotherapy previously and have a germline BRCA mutation. It could be BRCA1 or BRCA2. As far as advanced triple negative inflammatory breast cancer is concerned, similar principles to the other 2 subtypes of inflammatory breast cancer: incurable but treatable, generally no role for surgery or radiation unless for palliation, and the role of systemic therapy is palliative. You need to assess performance status, and palliative care, hospice, and advanced directives are important. But there are certain differences here. We typically check for PD-L1 CPS initially. If that is 10 or more, we offer patients chemotherapy with pembrolizumab, which is approved based on the Keynote 355 study, to use it as first line. There is also a role for PARP inhibitors like olaparib or talazoparib in those with germline BRCA mutations. You could also consider trastuzumab deruxtecan in those who have a HER2 low breast cancer, that is HER2 1 plus or 2 plus with FISH non-amplified, which is still reported as HER2 negative, but this subtype is considered HER2 low right now. And those patients who have progressed on at least 1 line of chemotherapy and have a HER2 low cancer could be candidates for this drug trastuzumab deruxtecan. And if they have bone lesions, then of course bisphosphonates or denosumab to reduce the risk of fractures. So there is role of clinical trials, definitely, just like any malignancy. Clinical trials are very important in terms of advancing science. And if we look at the NCCN guidelines, they clearly mention that the best treatment for a patient is a clinical trial. So standard of care is kind of a medicine option which is the best to date. It is established through clinical trials, may have more than one option available, and it's work in progress. So there is increase in, we always strive for increased efficacy, decreased toxicity. So that's the reason we try to keep building on the current standard of care. Clinical trials can be promising in the preclinical, and clinical data is important always, because everything that's promising in the preclinical phase may not always translate into survival benefit. Clinical trials should never be looked at as the last resort. There are different phases of clinical trials, phases 1, 2, 3, and 4, with the early phases like phase 1 typically looking at safety, 2 primarily looking at safety and efficacy, and 3 primarily looking at efficacy, and then subsequently 4. We always have to keep in mind the ethics associated with clinical trials. These clinical trials always go through rigorous peer review. They are not the so-called guinea pig experiments. And more information on these can be found at clinicaltrials.gov, looking for any particular clinical trials. And now I'll turn it back to Dr. Aft to discuss surgical treatment after neoadjuvant therapy.
So after the patients have completed their neoadjuvant chemotherapy, and that's for patients with locally advanced regional disease, local and regional disease, and not for patients who have metastatic disease, the first thing that we do as surgeons is we assess response to treatment. And this is usually by clinical exam and by imaging. And the imaging can be breast. It's usually a mammogram plus or minus an ultrasound to look at the lymph nodes, and then sometimes a breast MRI. If the patients have a good response to treatment, then we recommend surgery, and that would be removal of the breast or a total mastectomy, as well as an axillary lymph node dissection. If they don't have any response or very little response, then we consider additional chemotherapy or rarely preoperative radiation treatment. So this is an example of a patient assessed before and after their neoadjuvant chemotherapy. You can see on the panel on the right, this patient had a locally advanced inflammatory breast cancer. The dark areas in the breast area are her cancer, and the multiple dark areas going up towards her neck are lymph nodes that are involved. And she even has some supraclavicular lymph nodes involved. And this patient had an excellent response to neoadjuvant chemotherapy, as can be seen in this next slide, where almost all her cancer has disappeared. And this would be consistent with a complete radiographic response and make us optimistic that this patient will have no residual cancer cells at the time of her surgery. We do see many, many more patients who have complete pathologic responses at the time of surgery due to the increased effectiveness of combination chemotherapy with HER2 targeted therapies and the immunotherapy for triple negative breast cancer. So the standard of care is a modified radical mastectomy, which is removal of the breast as well as the level 1 and level 2 lymph nodes. And as you can see in the schematic, we remove the breast and the lymph nodes track up into the axilla. And the lymph nodes that we removed are all of the lymph nodes below the axillary vein, which are the level 1 and level 2 lymph nodes, which are shown by the dotted line outlining the breast. And then there are some level 3 lymph nodes on the other side of the pectoralis muscle. In patients with inflammatory breast cancer who had some indication by imaging or clinically that these lymph nodes would be involved, we do palpate for these and then remove them at the time of surgery also. Usually these patients, because they will require adjuvant radiation therapy, in general, we recommend that they complete all of their surgery and radiation therapy prior to reconstruction. However, due to the excellent response that many patients are having, some of these patients will undergo some sort of immediate reconstruction, for example, with an expander. The bottom two panels shows examples of patients who've undergone modified radical mastectomies, and you can see that they have a flat closure of their incision. To complete the local regional treatment for these breast cancers, patients undergo radiation treatment, and this usually begins about 3 weeks after surgery. And you can see that this patient has been marked for her radiation treatment. And in general, these patients will undergo radiation to the entire chest wall, including the flaps. Sometimes they'll include the internal mammary lymph nodes, which lay behind the sternum. The lymph nodes under the arm are included, and usually a third field is included in the supraclavicular area. By using this tri-modal therapy of chemotherapy, surgery followed by radiation, this results in the lowest risk of local, regional, and systemic recurrence for patients, and that's why we recommend this sequence of therapy for them. So in follow-up, these patients undergo frequent physical exams. We assess them for arm lymphedema because undergoing an axillary lymph node dissection as well as radiation to the axilla increases the risk of arm lymphedema to approximately 30 to 40%. And then we do frequent imaging of these patients. And that can be repeat staging studies with a PET scan and imaging of their contralateral breast. So to summarize, inflammatory breast cancer is often mistaken for an infection. Usually 1/3 of the breast is inflamed. It's a clinical diagnosis, and biopsy, either a skin biopsy or a core biopsy under imaging, can confirm the diagnosis. Dermal lymphatic invasion, which I showed you earlier, is characteristic but not required for diagnosis. And we always perform staging studies to ensure that these patients do not have any evidence of distant disease. And if they do not, then we treat them aggressively with local regional treatment to attempt to cure these patients. And I'll turn the presentation over to Jenny now.
Thank you, Dr. Aft. Well, I am going to be speaking to you today from a patient advocate perspective. Why am I an advocate, or why did I get involved in advocacy? Because my own diagnosis was delayed by nearly 5 months from the onset of my symptoms because no one would take my symptoms seriously. The medical community clearly was unfamiliar with the disease, and sadly still many are, particularly in the community setting. The focus tends to be in our society on mammograms and lumps, overlooking that there are other breast cancer symptoms that we need to be aware of. And I definitely learned about the need for education in both the general population and broader medical community. And it's obvious as I got more and more involved, the need for basic research and clinical trials in inflammatory breast cancer, since the condition is usually excluded from clinical trials, unless it is an IBC-specific clinical trial. And sadly, a high percentage of us have metastatic disease at diagnosis, or called de novo. I was very fortunate. Mine was not de novo. Well, you've already heard the things you'll see on this slide. You've heard this is a very aggressive disease, and it is considered an advanced breast cancer at diagnosis. Unfortunately, the symptoms can come on extremely fast. It accounts for only about 1 to 5% of breast cancers based on the SEER data. But we know that when you're looking at a disease with a low penetrance like IBC, SEER data may not be the best way to look at statistics. We tend to be younger at diagnosis, and women of color are more likely to be diagnosed with IBC. And sadly, we're often misdiagnosed. As you heard before, this is often mistaken for an infection called mastitis. About 1/3 of us will have metastasis at the onset, and another third will become metastatic at some point during the course of their disease. And right now, there are no targeted therapies for inflammatory breast cancer. As you just heard on the last slide, IBC is typically treated with a tri-modal therapy: chemotherapy, surgery, and radiation therapy. I'm part of an organization called the Inflammatory Breast Cancer Research Foundation. Way back in the old days when the internet was very new, I was diagnosed in 1994, by the way, with estrogen negative and progesterone negative breast cancer, inflammatory breast cancer, and mine was a invasive ductal cancer. At that time, we didn't even know about HER2. I was able to meet up with someone online when I was doing research, when I had gone back to get my bachelor's degree in nursing. And I met some others who were interested in research for inflammatory breast cancer. So we formed the Inflammatory Breast Cancer Research Foundation back in the summer of 1999. We're an all-volunteer 501c3. We have been web-based since the beginning. We have no staff, no office. The third bedroom of my home is the office. And we have an outstanding medical advisory board who reviews our materials. So you can be confident that whatever you find on our website is good, sound medical information. We facilitate and fund research. And one of our big things is to provide education and one-on-one support to patients and their families by phone and email. One of the things I'd like to share with you is, as you've heard, how inflammatory breast cancer is difficult to diagnose because none of us have the exact same symptoms. It can be very subjective. And it was a frustration for me that over the years, we continue to encounter patients who are going as long as 5 or 6 months with symptoms back and forth to their doctor, and it's getting progressively worse, and just can't get someone to take it seriously, especially younger women. We joined forces with the Komen Foundation and a private group called the Milburn Foundation and put together something called the IBC Collaborative. We got together the first time about 6 years ago, and we were talking about how to prioritize research. We had raised some funds together. And as I traveled to that meeting, I thought about that we still really need to improve diagnosis. Mammograms just are not as helpful as we'd like. The outcome of that first meeting was we needed to come up with a better diagnostic system and better actually describe what inflammatory breast cancer is to increase the diagnostic accuracy. And in January of 2022, we published our findings, this diagnostic scale we put together in Breast Cancer Research and Treatment. And that study, the information from that diagnostic code is being validated now at both MD Anderson's IBC clinic and Dana-Farber's IBC clinic. And we hope to have initial results to present at the San Antonio Breast Cancer Symposium this December. This is a little bit of the information you would find on the IBC scoring system. This is designed to be used in the doctor's office with their physician, but a patient can go through this. They can look at the documentation that we had in the publication from 2022. It's available online. And you can look through this yourself and see, where do you think you would score? We look at these kinds of areas of the breast, the different symptoms that you might see, as well as if there's been breast imaging done. And you can come up with a score, and you can see if it comes out definitely IBC 42 to 48. And then we have a strong possibility, weak possibility, and not IBC. And the idea is that initial physician or healthcare provider who's meeting with you can look at this and say, I really need to get you straight to a surgeon. Or maybe it is worthwhile to try an antibiotic before we move on. I wanted to share that with you to let you know that advocates, patient advocates, can do something important. You can make a difference. I'll admit, There are days when I'm frustrated because I've spent time trying to help a patient find appropriate treatment, or we've searched for clinical trials that would be useful to that patient, and we're not successful. Sadly, I've lost more friends than I'd like to even mention. You learn to cope with that as an advocate. But I've also learned that you can do amazing things when you get a group of people together and get people to listen. We've been able to do almost $500,000 worth of research. We've been able to educate folks, and we've been able to help individuals cope with the disease. That's really challenging. This slide tells you a little bit more about the kinds of things you can do, because I know we have a lot of patients participating in this today. You can tell your story. October is a great time to go to your local newspaper or your TV station. Get them to do a story about your inflammatory breast cancer. You know, talk to most anybody who will listen. I always carry brochures with me for my organization and give them out when I'm in a doctor's office. I might be at physical therapy like I did last week and gave that out. You can find all kinds of ways to be an advocate and to make sure that people understand inflammatory breast cancer is a difficult disease, and it's not just, as I say, garden variety breast cancer. We need to make sure people understand there are symptoms beyond a lump that you hear about all the time, especially in October. We use black, red, and white in our logo because we don't want people to think of inflammatory breast cancer as pretty and pink. Unfortunately, we've kind of pink-washed breast cancer. But as a 29-year survivor of the disease, I look forward to working myself out of a disease and a job. Thank you.
Thank you. Thank you again to all of our presenters. We just have an acronym slide, which you can look at. So we're going to begin the Q&A session shortly. You may now submit your questions to the presenters. Please use the Q&A box and not the chat box. We also have a medical disclaimer, if you wanted to go back, Mark. We are not giving medical advice about specific treatment decisions. You should always talk with your healthcare team. Okay, next slide.
Could I just add something?
Sure.
I would just like to thank Ginny for that insight. I think that's so important because I'm a breast surgeon, so I see this all the time, and I have a low index of suspicion. But many of my patients come to me after they've gone through multiple rounds of antibiotics, or they say they know there's something wrong with their breast, but nobody can put their finger on it. And it's really true. We do need to educate the community that breast cancer can present without a lump. It can just be skin changes. And if women do notice something, skin changes or something that doesn't seem quite right, they should seek expert or attention for their breast and maybe go beyond their primary care physician to a breast specialist.
I agree. I encourage people to make sure they keep asking questions until somebody pays attention. And that can be hard to do. It's something that I had difficulty doing early on. But I've learned over time that I have to be my own advocate.
What would you say is the incidence of inflammatory breast cancer in those assigned male at birth? How often do you see inflammatory breast cancer in that population? Almost never?
I've almost never seen it. The only thing I've seen, I see male breast cancer, and that's not frequent either. I think it's about 3 to 5% of breast cancer patients. But in people assigned male at birth, I've seen in my career, I think I've seen one case of DCIS. Dr. Chris Murphy, have you seen it?
Yeah, no, not yet seen an inflammatory breast cancer in a male patient, but yeah, it has been reported, but I personally haven't seen one.
I know I've worked with 3 different gentlemen with inflammatory breast cancer, one outside the US, but the other 2 in the US.
So I'd like to thank everyone for joining. I am reading the Q&A and some of the comments. We do have people from around the world. I just saw someone from Costa Rica. So welcome all for those of you who are joining us. So I see this one comment about the ocular side effects from tamoxifen. Let's see. A client of ours mentioned that she has been diagnosed with tamoxifen toxicity with macular cube maculopathy from tamoxifen OU. Can you tell us more about that?
Yeah, I have only a handful of patients developed cataracts on tamoxifen. I'm yet to come across this macular cube maculopathy kind of situation. But typically, we recommend patients to see an ophthalmologist right away when they see vision changes on tamoxifen. But again, the reported incidence of cataract also has been less than 1%, so it's not something very common.
Okay, thank you. We do have a question about the risk of recurrence after this tri-modal therapy. I don't know who wants to field that, or if it's based on, you know, the receptors, what. Yes, okay.
Yeah,
See.
I think it's a loaded question because it totally depends on which receptors are positive, what treatment they get, whether they achieve pathologic complete remission or not. There are so many variables there that it's difficult to put a number on that.
Yeah, I think also within the past, even 5 years, we've had newer treatments for inflammatory breast cancer. And I don't know that we have the long-term results back yet in this specific population. For example, there's so many new HER2 targeted treatments and the PD-L1 inhibitors that I think we're going to, I mean, all the data that we have is like retrospective from 2013. I just looked that up. There's a recent paper on the SEER data, but that's data that goes up to 2013, which is even 10 years older than it is now. So I think it does depend on a lot of factors, and I think it's improving all the time just because our therapies are.
I would agree. In working with patients now for almost 25 years, you know, I'm an anomaly myself to be 29 years out. When I was diagnosed, I think the National Cancer Institute information they sent to me said I had a 3% chance of being alive in 5 years. And my response to my doctor when I mentioned that was, I said, well, I took statistics in college. I know someone has to be in that 3%. I'm aiming for that.
So we have, let's see, a few more questions. So there are a couple of questions about imaging. So how do you determine what imaging to do? There was one about like a PET scan, you know, why a PET scan might be done over just a regular bone scan or an MRI, for example.
So, when we order staging studies, sometimes that's done by the surgeon and sometimes by the medical oncologist. And I think it's just preference or institution preferences but I usually, in the past, I've always ordered a CAT scan and a bone scan. But recently, the PET scans have been approved for staging studies and have been added to the NCCN guidelines. So more and more insurance companies are approving PET scans for staging for breast cancer. So my preference is actually to order a PET scan and not a bone scan and CAT scan, unless the insurances won't pay for it. And then I'll order a CT scan and bone scan. And then if there's any questionable finding, order a PET scan after that. Dr. Krista Murphy, do you have any thoughts on that?
Exactly, that's exactly how we do it. We try to get a PET scan because I think it does, especially our radiation oncologists feel that From radiation planning perspective also, and looking at supraclavicular lymph nodes, PET scans help a lot more. But as you rightly pointed out, there are certain insurances which deny PET scans, and in those cases, the next best option is to do a CT scan and a bone scan.
Great, thank you. I did find the imaging examples very helpful in the slides, as I'm sure our attendees did. And then, so one question is the only surgery mastectomy. So I guess the question is radical modified mastectomy with the axillary lymph node dissection. So is that the only option? Is that the only
So,
surgery?
I will tell you that there are no prospective clinical trials comparing breast conserving surgery versus mastectomy in patients with inflammatory breast cancers. And in general, because there is skin involvement and we want to know if there's any residual cancer cells in the skin, we generally do recommend a mastectomy. But having said that, we've had some in the literature, there have been some retrospective studies where what they've done is in those patients who have these really remarkable responses, whereby imaging all of their cancer has disappeared, patients have been offered, especially if there's an underlying mass that they can excise, they have been offered breast conserving surgery. Now, having said that, we never know if there's any residual cancer cells until we actually remove the tumor. We do, or the skin and any underlying tumor, because we do not have imaging sensitive enough to look for microscopic residual cancer cells. There have been a couple clinical trials trying to do that, to identify patients who've had a complete response pathologically, to identify them by imaging who may, possibly may not require surgery. But those trials have not been found to be sensitive enough to not recommend surgery in any patient. So I think it depends, number one, on the extent of the disease when the patients are diagnosed. And it also depends whether there's an underlying tumor mass. If there's no underlying tumor mass, then pretty much a mastectomy has to be performed, because otherwise we don't know where our cancer is, except for the skin. In terms of axillary surgery, many of these patients present with multiple axillary lymph nodes. Some of them present with fewer axillary lymph nodes. Again, in those patients with multiple axillary lymph nodes involved up front, we'd like to know if there's any residual cancer cells in those lymph nodes. Recently, patients who have tumors and are undergoing neoadjuvant chemotherapy, we've been doing what's called targeted axillary lymph node dissections. But I don't know if this has been migrated really to the inflammatory breast cancer patient population. Since this patient is at such high risk of recurrence, local, regional, and systemic, we really want to be sure, we really want to know exactly how much residual disease they have. And so we try to do a mastectomy and axillary lymph node dissection.
So Dr. Aft, do you find that someone goes to like the primary care physician, or they're at the gynecologist, right, and then they have these possible signs, so imaging might be ordered. Do you find that the patients are referred to you, and then they would come to you, Dr. Krishnamurti, or would you talk to one another? Like how does the order work with how you communicate? Or I mean, so you know what I mean?
So usually these patients need a diagnosis before we send them to medical oncology, because their treatment recommendations are based on the extent of the disease and the tumor biomarkers.
Yeah, at our institution, because every patient with newly diagnosed breast cancer is seen as part of a multidisciplinary clinic. So the surgeon, radiation oncologist, medical oncologist, genetic counselor, social worker, everybody ends up seeing the patient the same day at the initial visit. And we have reviewed their imaging and history beforehand and come to a consensus as to how we were planning to treat, so that a unified message can be given to the patient.
Okay, great. Thank you. A question about what kind of ovarian function suppression is used?
Typically, we use goserelin, which has the maximum evidence in breast cancer for ovarian suppression. Other options do include leuprolide, sometimes ovarian ablation, which we don't use usually, but in the marquee clinical trials, SOFT and TEXT, based on which ovarian function suppression became standard of care. Ovarian ablation was also an option. Of course, the other option is removal of ovaries called oophorectomy, but that is permanent menopause, so very young patients. We usually don't try to do that unless they have a germline BRCA mutation where they're at high risk for ovarian cancer, because the ovarian function suppression that we use can be temporary and their ovarian function could potentially resume after completion of that. So whatever benefit of estrogen they could derive, they can still have that with the help of ovarian function suppression being temporary.
Thank you. Are PARP inhibitors only used for BRCA mutations, or do they work with other mutations such as PALB2?
So with the PALB2, there is some evidence that there could be benefit of PARP inhibitors, but no large randomized trials have been done. The largest randomized clinical trials, Olympiad, which was done in metastatic BRCA mutated patients, used olaparib. There was MBRCA, which used talazoparib in the advanced stage BRCA mutated patients. And in the localized disease setting, there was Olympia for adjuvant olaparib. So that's why the FDA approval at this time is restricted to BRCA mutated patients in breast cancer.
And Ginny, maybe you could answer this. We do have people from other countries, and one person is from Australia, and they're trying to find out how you would find a specialist in a country or in their area.
Typically, I tell people to search out a breast cancer organization in your country, and usually they'll be more aware of where particular kinds of specialists might be. If the hospital where the person is being treated has a nurse navigator, they can be helpful as well. But I know I do some global advocacy work. I'm part of the Metastatic Global Alliance and have learned to know advocates in other countries and will often refer patients who contact us because they may come to us from anywhere in the world through our website and be looking for someone who has expertise in IBC. And I'll often reach out to someone in their country who runs a breast cancer organization. They tend to know where the specialists are and know more about what's available in their country.
Another question about, do we know why IBC has a higher rate of metastasis?
Because this type of cancer typically has dermal lymphatic invasion already. That's the reason with skin involvement, it is already a stage 3 cancer at least at the time of presentation. And studies have shown that because of that locally advanced nature that already is there, there is a 15 to 20% chance of finding distant disease in these patients. And that's the reason staging scans are very important in patients with inflammatory breast cancer.
I think also, if you think about breast cancer, most breast cancer is made to is from the breast tissue, and it's really made to live in the breast. But inflammatory breast cancer has developed these special biological skills where it can actually go into the lymphatics more readily than and that's the definition. So for example, even if if a woman has a regular cancer and there's what's called lymphovascular invasion, that's a poor prognostic sign because those patients' cancers have acquired the biological ability to get into the lymphatics, and that can spread throughout the body. And the inflammatory breast cancers have acquired this ability to go into the lymphatics better than almost every other breast cancer. And they do it they do it well, and that's why we find it in the dermal lymphatics, as well as in the lymph nodes, because they've traveled to the lymph nodes or within the breast in the lymphovascular space.
Great, thank you. There were kind of two questions about imaging. I guess but I see them as relating to how do you recommend people advocate for themselves? So not everyone has access to a multidisciplinary team, especially if they're in a rural area, in a community area, community hospital, or maybe you really want an imaging to see how your treatment is progressing, and that your healthcare provider, your oncologist might want to wait. So I guess a twofold question, like how do you advocate, but also I guess how do you get what you need? You know, you don't always get the answers you want, but how do you have those conversations? Loaded question, I know. Ginny, you want to start?
Okay. We get those questions a lot. And one of the things I will frequently tell a patient, if you are questioning about your standard of care in your institution, especially as you say, in a rural area, where you may not even have a breast oncologist, you have a general oncologist, find out if they'd be willing to talk to someone at one of the IBC clinics. And that way they can get that specific information and guidance from someone who sees a lot of patients at places like MD Anderson and Dana-Farber. There's another one at Duke now too. And those are physicians who see lots and lots of cases and are more than happy to guide a local physician in terms of treatment and what would be considered standard of care for inflammatory breast cancer. And I also just encourage people to direct their doctor to the NCCN guidelines because, you know, even as a patient, you can go in and print those off yourself and say, you know, this is what's recommended by your peers. So this is what I should be receiving. When it comes to getting extra imaging, that can be challenging because it could be related to insurance and things like that, that they won't cover it. But I know there are ASCO guidelines that are frequently followed that don't use a lot of imaging unless there's a call for it. And that can be challenging because we want to see what's happening. We all like to know what's going on ahead of time, and sometimes that's difficult to know.
I would just like to echo what Ginny said. I think if you looked at the map of the National Comprehensive Cancer Institute, comprehensive breast cancer centers, they're distributed throughout the United States, and most comprehensive cancer centers will have an enormous experience dealing with inflammatory breast cancers, because most of these comprehensive cancer centers are high volume cancer centers for breast cancer. I think I know we see patients who will drive several hours to come see us in St. Louis, and then we'll let them know our recommendations, and they'll take that back to their treating physicians locally.
Do you have anything you'd like to add to that, Dr. Krishnamurti?
Yeah, no, I think, as mentioned previously, looking at the NCCN guidelines always helps. Many of my patients actually print those off the NCCN website so that they already have a fairly good understanding of what we are going to discuss. And I think it also makes a lot of sense to them at that time when we are presenting newer facts and treatment options, because a lot of times the first visit can be very overwhelming. So looking at these guidelines beforehand, at least getting some idea about it, and then they also know how to ask the right questions. So I think it has been very helpful to my patients.
Great, great. Thank you. So some really excellent questions, great conversation. Thank you for everyone who attended. And thank you for those of you who have shared your stories that we were unable to share with our panelists, but I assure you we all did read your comments, and thank you for sharing those. The NCCN Foundation would like to also thank our corporate supporter of this webinar. Thank you again. Have a great day.